My name is Carolyn Kassabian. I'm a dermatologist in private practice in Mission Hills. And today I will be talking to you about skin cancer diagnosis, treatment, and prevention. Skin cancer is the most common cancer in the United States. Current estimates are that 1 in 5 Americans will develop skin cancer in their lifetime. Everyone is at risk. Millions of cases are diagnosed each year. On the bright side, it is also one of the most preventable cancers and highly treatable when found early. The 3 types of skin cancers I'll be discussing today are basal cell carcinoma, which is the most common type of skin cancer, accounting for 75% of cases, then squamous cell carcinoma. Basal cell and squamous cell are collectively referred to as non-melanoma skin cancers. The third major type of skin cancer is melanoma. Basal cell carcinoma is the most common form of skin cancer, with an estimated 3.6 million cases diagnosed in the United States each year. It is found on sun-exposed skin of the face, ears, the scalp, especially a bald scalp, shoulders, and neck. On the molecular level, nearly all basal cell carcinomas have a constitutive activation of the hedgehog signaling pathway, which leads to an uncontrolled growth of the basal cells in the epidermis, the top layer of the skin. Basal cells grow locally, and they can cause significant local destruction and disfigurement, but it is very rare for them to metastasize. For basal cell development, the main risk factor is ultraviolet radiation, particularly intermittent, intense sun exposure, such as in sunburns. Indoor tanning is also a well-established risk factor. UV radiation is the most important risk factor and the one that is preventable. Other risk factors include fair skin, older age. Basal cell does have a slight predilection for males over females. There are some genetic medical syndromes that are very rare, but they do increase your risk of developing basal cell carcinoma. Anything that weakens your immune system increases your risk of getting this skin cancer. So if you received an organ transplant, the medication that you take to prevent your body from rejecting the organ transplant suppresses your immune system. This increases your risk of developing basal cell carcinoma on the order of 5 to 10 times above the general population. Basal cell carcinomas start out very innocently, like a pimple or an insect bite, but they do not resolve, and instead they grow locally over time. Patients report that they sometimes itch and they bleed easily, either on their own or with trauma, such as from shaving. Nodular basal cell is the most common subtype of basal cell, comprising 50 to 80% of all basal cells. We describe basal cell carcinomas as translucent, meaning that you can see through them. Also as pearly, because they have a shine to them. Over time, they become sunken in the center and are sometimes called rodent ulcers, as they look like a rodent has taken a bite out of the skin. Superficial basal cell is the second most common subtype, comprising 10 to 30% of basal cells. They occur most commonly on the trunk and in younger patients. Pigmented basal cell looks like a nodular basal cell, but it is darker in color instead of pink. This pigmented type occurs more commonly in darker-skinned individuals. The differential diagnosis would include melanoma. Morphea-form basal cell looks like a white, waxy scar without a clearly defined border. Basosquame has features of both basal cell and squamous cell carcinoma. Morphea-form and basosquames are more aggressive forms of basal cell carcinomas. So how do we diagnose basal cell carcinoma? Typically, you have a high index of suspicion just by the clinical appearance of the basal cell. But you can also use dermoscopy, which allows for better visualization of the suspicious skin lesion using a dermatoscope. Then you would perform a shave biopsy to confirm the diagnosis on histopathology. Excision is the mainstay of basal cell carcinoma treatment. If the cancers are excised with a 4 mm margin of normal skin, there is a very low chance of recurrence. Mohs surgery is commonly used as a treatment for basal cell carcinoma, especially in areas where skin conservation is important. I'll discuss Mohs in further detail in the next slide. Electrodesiccation and curettage is an option for small basal cells. It's a quick procedure that is well tolerated and is very cost effective. It avoids surgical repairs with deeper excisions. My older patients commonly prefer this over Mohs surgery. Topical therapy is used more commonly for actinic keratoses, but it is approved to treat superficial basal cell carcinomas. Typically, we prescribe either 5-fluorouracil or imiquimod to treat superficial basal cells. Photodynamic therapy is a treatment that uses a light-sensitive chemical and a light source to destroy abnormal cells. Radiation therapy can be very effective for large head and neck cancers, especially ones that have nerve involvement. It is well tolerated and very effective, but requires multiple sessions in a facility over several weeks. In basal cell pathophysiology, there is an upregulation of hedgehog pathway, which causes activation of the cancer-related genes. There are a few hedgehog pathway inhibitors that are FDA approved for the treatment of locally advanced basal cell carcinoma. Our secret code is Mohs. Mohs surgery is the gold standard treatment for removing basal cell carcinoma. It is the most effective technique for removing skin cancers harming minimal healthy tissue while achieving the highest possible cure rate. Up to 99% of tumors treated for the first time do not recur. It is recommended in areas where you want to spare as much normal tissue as possible, such as the face. The procedure is done in stages, all in one visit, while the patient waits in between each stage. After removing a layer of tissue, the surgeon examines it under a microscope in an on-site lab. If any cancer cells remain, the surgeon knows the exact area where they are and removes another layer of tissue from that precise location while sparing as much healthy tissue as possible. The doctor repeats this process until no cancer cells remain. And then the Mohs surgeon performs a flap or a graft or allows the area to heal in on its own, depending on whichever option will produce the best cosmetic result. The prognosis of basal cell is typically very good. The major concern is if it's been neglected for a long time, there can be local invasion and tissue damage. Metastasis is very rare, less than 0.1% of cases. Squamous cell carcinoma is the second most common skin cancer, with an estimated 1.8 million cases of squamous cell carcinoma diagnosed in the United States each year. Although squamous cell carcinoma most commonly occurs on sun-exposed skin, it can also develop in different regions of the skin, as well as other sites lined by squamous epithelium, such as the mouth or esophagus. The biology of cutaneous squamous cell carcinomas differs from squamous cells cancers that are in other tissues. The ones that develop on the skin exhibit a more indolent behavior, and the development of metastasis are very rare, although it does occur. For the rest of this presentation, I will only be talking about cutaneous squamous cell carcinomas. On the molecular level, squamous cell carcinoma most commonly has a mutation in p53, which is a tumor suppressor gene, and this leads to uncontrolled growth of the squamous cells in the epidermis. Many other mutations have been identified. Squamous cell carcinomas can metastasize to lymph nodes if left untreated. Squamous cell carcinomas can have a variable presentation on the skin. They can be crusted or scaly, papules or nodules with a red inflamed base. They can grow slowly or very rapidly in the matter of a few weeks. Some are painful and others have no pain whatsoever. Squamous cell carcinoma is clearly linked to UV radiation. For squamous cell carcinoma, it is the accumulated lifetime risk that is most significant. Fair skin is also a risk factor, although squamous cell is the most common skin cancer in Hispanic, Black, and Asian patients. The incidence is 5 to 10 times higher in individuals above the age of 75 compared to those younger than 55. And there is, again, a male predilection, 3 to 1 over females. Immunosuppression in organ transplant recipients increases the risk of squamous cell carcinoma significantly, 65 to 250 times the risk for those in a general population. Certain genetic syndromes can predispose to squamous cell carcinoma, as can chronic inflammation in a particular site. HPV plays a factor in periungual and anogenital squamous cell carcinoma, as does exposure to certain chemicals such as arsenic. Actinic keratoses are precancerous lesions that may progress to cutaneous squamous cell carcinoma. They are rough, red macules and papules on sun-damaged skin of the head and neck, upper trunk, and extremities. They are more easily felt than seen. They have a rough texture like sandpaper. The majority do not turn into squamous cell carcinoma, but a small percentage do. That number ranges from 0.1 to 20%. Since we do not know which ones will turn into squamous cell carcinoma, AKs are typically treated to prevent that transformation, most commonly with freezing with liquid nitrogen. Squamous cell carcinoma is diagnosed by biopsy to distinguish it from precancerous actinic keratosis, to in situ squamous cell carcinoma, and invasive squamous cell carcinoma. Squamous cell carcinoma can range from well-differentiated to poorly differentiated, highly infiltrative tumors. There are several different staging systems for cutaneous squamous cell carcinoma, including the American Joint Committee on Cancer staging system and the Brigham and Women's staging system. Staging is critical for the appropriate management of squamous cell carcinoma. Depth of invasion, perineural invasion, histologic differentiation, and patient immunosuppression are the main high-risk features of squamous cell carcinoma. High-risk tumors comprise less than 20% of cases, but cause most of the nodal metastases and deaths. High-risk tumors are best managed in a multidisciplinary setting. So for squamous cell carcinoma treatment, if it is a localized lesion that is low risk, then the recommended treatment would be wide local excision with 4 to 6 millimeter margins of normal skin. If it is a localized lesion with high risk, then it would be wide local excision with 5 to 10 millimeter margin of normal skin or Mohs micrographic surgery. Radiation therapy is reserved for poor surgical candidates or can be used as adjuvant therapy. Systemic therapy is reserved for recurrent, locally advanced squamous cell carcinomas and poor surgical candidates, also those with regional or metastatic disease. There is limited response to conventional chemotherapies, and immune checkpoint inhibitors are the preferred treatment. Nodal metastasis occurs in 1.9 to 5% of patients, but in those patients with solid organ transplants, the metastasis rate is much higher, 7 to 11%. Overall, the mortality ranges from 1.5 to 3.4%. The absolute number of patients with nodal metastasis and death is equal to or greater than those for melanoma. Keep in mind that melanoma is more deadly, but squamous cell is much more common than melanoma. Last, the third type of skin cancer we'll be discussing today is melanoma. It's the third most common type of skin cancer. The estimated number of cases of melanoma in the United States in 2024 is 200,000. Keep in mind that the non-melanoma skin cancers were each on the order of millions of cases. But melanoma is the deadliest form of skin cancer and is responsible for more than 75% of skin cancer deaths. It is a malignant tumor from the pigment-producing cells called the melanocytes. On the molecular level, the gene that is most commonly mutated in melanoma is called BRAF, B-R-A-F, although there are multiple different mutations that have been identified. Melanoma can appear suddenly in normal skin in 70 to 80% of cases, or it can develop from an existing mole. It's most commonly found on the upper back, trunk, lower legs, and head and neck. It can spread to lymph nodes and internal organs and causes more than 75% of skin cancer deaths. The incidence of melanoma has been increasing since the 1950s in fair-skinned individuals on the order of about 3 to 7% per year. The cause of this increased incidence is controversial. Is there an overdiagnosis by dermatologists and pathologists? Or are we screening more and detecting melanomas earlier and it's not a true increased incidence? Fortunately, the mortality rates seem to be stable or reveal a decreasing pattern. These findings might reflect the effectiveness of public health policies, healthcare systems, and awareness campaigns, resulting in more diagnoses of early-stage melanoma, which then leads to better treatment options and algorithms. Risk factors include skin that burns easily, so those with fair skin, with natural blonde or red hair, and light-colored eyes. The incidence of melanoma among white individuals is almost 30 times higher than among Black or Asian. Also, very significant risk factor is a history of excessive sun exposure, including sunburns and tanning bed use. Other risk factors include a weakened immune system and a personal or family history of melanoma. Melanoma survivors have an approximately 8-fold increased risk of developing another melanoma compared to the general population. People with more than 50 moles, atypical or large moles, are at increased risk of developing melanoma. So what is a dysplastic nevus? First of all, nevus is our word for mole. Dysplastic nevus are moles with atypical morphological features. So they are asymmetrical, they have irregular borders, and they have color variations. If you biopsy one of these, there will be mild, moderate, or severely atypical architectural and cytologic atypia on biopsy. These are quite common in the population. About 10% of the population has a dysplastic nevus. It's controversial as to what they are. Are they a precancerous mole that's going to turn into a melanoma down the road, or is it just a marker for increased melanoma risk? Dysplastic nevi are found in about 40% of melanoma patients. If you have 5 dysplastic nevi, that increases your risk of melanoma tenfold. The most common subtype of melanoma is known as superficial spreading melanoma. This has a low cumulative sun damage. It occurs on the trunk in men and legs in women. Happens more commonly in younger and middle-aged patients. It appears as a brown or black macule with color variations and irregular notched borders. It can arise out of the blue or in an existing mole. It has a long radial or horizontal growth phase before it starts growing vertically. Nodular melanoma accounts for about 15 to 25% of melanomas. The tumor grows deeper into the skin more rapidly than other types and is most frequently found on the trunk, extremities, as well as the scalp in older men. It is usually invasive at the time it is first diagnosed. It can appear blue, brown, or black bump or nodule, and it can be amelanotic, so it's pink or red. And as I said before, it has a very quick vertical growth phase and is considered the most aggressive type of melanoma. Lentigo maligna melanoma is common in older patients with extensive sun exposure, and it's often mistaken for sunspots. It happens most commonly on the head and neck. It is a slow-growing, asymmetric brown or black macular patch with irregular borders. It has a long radial growth phase, and it takes time for it to start developing vertically. Acrolentigenous melanoma is a relatively uncommon type of melanoma, but it is the most common type of melanoma found in people of color. It typically occurs on the palms and soles or around the nails. Musician Bob Marley was diagnosed with acrolentigenous melanoma, which ultimately claimed his life at the age of 36. He had a dark spot appear under his toenail. He attributed to a soccer injury. Eventually, he was diagnosed with melanoma, but he refused the recommended treatment, which would be surgical removal of the toe. His melanoma spread to other parts of his body and tragically cut his life short. So how do we diagnose melanoma? Well, we've all heard of the ABCDE system, and I'd like to go over that briefly. A stands for asymmetry. So if one half of the mole doesn't match the other half, that is something to be concerned about. B stands for border irregularity. If the edges are ragged, notched, or blurred, that is something to be concerned about as well. C stands for color. The pigmentation is not uniform. There can be different shades of brown and black in melanomas. There can also be ashes of red, white, and blue, which also adds to the mottled appearance. D stands for diameter. While melanomas are usually greater than 6 millimeters in diameter, the size of a pencil eraser, they can be smaller. E stands for evolving, a mole or new skin lesion that is changing in size, color, or shape. If a change is noted in the lesion, this is the most significant sign for melanoma. Another helpful tool is known as the ugly duckling sign. You want to look for the one lesion that stands out or looks different from the rest. The American Academy of Dermatology urges everyone to examine their skin regularly. This means looking over your entire body, including your back, having somebody check your scalp, your feet, under your toes. If you notice a mole that looks different from the others or which has changed or itches or bleeds, you should make an appointment to see a dermatologist as soon as possible. And I forgot to mention the correct diagnosis of melanoma is improved by about 50% in experienced practitioners who are utilizing dermoscopy. So how is melanoma diagnosed? We need to have histological confirmation. You would have a high clinical suspicion for it, and the recommendation at that point would be to do an excisional biopsy to prevent sampling error and avoid transection. So you either want to do an elliptical excision of the lesion with 1 to 3 millimeter margins of normal skin, or a punch biopsy, or get a deep shave or saucerization of the lesion. Staging is done by TNM staging system. T standing for tumor. Classification is determined by Breslow depth and histopathological presence of ulceration. The tumor thickness can range from TIS, which is melanoma in situ, to T4, which is more than 4 millimeters in thickness. In the TNM staging, N stands for nodes. So the node stages indicates lymph node involvement, whereas the M metastasis describes whether the cancer has spread. The prognosis of melanoma is directly correlated with the Breslow depth and survival. The 5-year survival rate for melanoma that is detected and treated before it spreads to lymph nodes is very, very good, on the order of 99%. The 5-year survival rate for melanoma that spreads to nearby lymph nodes is 74%. The 5-year survival rate for melanoma that has spread to distant lymph nodes and other organs drops to 35%. These numbers show how important early detection and treatment are for improved survival. What are the other prognostic indicators besides tumor thickness? Ulceration, mitotic rate, age, gender, anatomic site, lymph node involvement, and the presence of distant metastasis. For the treatment of melanoma, you want to re-excise the melanoma with appropriate margins. The thickness of the tumor at the biopsy indicates the excision margins that need to be taken. So for an in situ melanoma, you would need to excise it with either 0.5 centimeter to 1 centimeter margins of normal skin. It is also customary to get a sentinel lymph node biopsy for melanomas that are greater than or equal to 1 millimeter in thickness, so staging T2A and deeper. Why do we get this sentinel lymph node biopsy? It is the best prognosis for survival and recurrence. For patients with distant metastasis, systemic therapy is the mainstay of treatment. Melanoma is a highly immunogenic tumor, which makes it ideal for immunotherapies. Immunotherapy is the use of medicines to help a person's own immune system recognize and destroy cancer cells more effectively. Several types of immunotherapies can be used to treat melanoma. The largest category is immune checkpoint inhibitors, which are superior and less toxic than traditional chemotherapy. Some viruses can be altered in the lab so that they infect and kill mainly cancer cells. In addition to killing the cells directly, the viruses can also alert the immune system to attack the cancer cells. So for the prevention of skin cancer, I want to stress that the sun exposure is the most preventable risk factor for all skin cancers, including melanoma. You can have fun in the sun, but you need to be smart about it. To be sun smart, generously apply water-resistant sunscreen with an SPF, sun protection factor, of at least 30 that provides broad spectrum protection from both UVA and UVB rays to all your exposed skin. Remember, SPF is only referring to protection from UVB. That is why you need to make sure your sunscreen also says broad spectrum to have coverage for UVA as well. Ideally, you should apply to dry skin 15 to 30 minutes before going outdoors. Be sure to apply it to all your exposed skin. Pay particular attention to the face, scalp, ears, hands, and arms. Coat the skin liberally and rub it in. Most people only apply 25 to 50% of the recommended amount of sunscreen. 1 ounce, enough to fill a shot glass, is considered the amount that is needed to cover the entire body properly. A nickel-sized dollop to cover the face alone. Don't forget the lips, as they can get sunburned too, so apply a lip balm with an SPF. Daily sunscreen use is an important factor of sun protection. Other steps include seeking shade, wearing a wide-brimmed hat and UV blocking sunglasses, and covering with a UPF clothing. I want to point out that environmental factors like water and sand can reflect up to 80% of UV radiation, so the sun's rays are hitting you twice, from above and also from the reflection. Even on cloudy days, UV radiation reaches us, so sunscreen needs to be worn daily. The last part of my presentation, I want to go over some pictures of my own patients. And so this first one is an elderly lady with what looks to me like a rodent ulcer right by her eyelid. So this is a basal cell carcinoma. Next, we have a darkly pigmented, irregular macule with clearing in the middle. And you can tell it's very irregular, notched. This is a melanoma on the upper back of a gentleman. Next, we have an area by the temple of an elderly gentleman. It is dark in color, but this is actually a pigmented basal cell and is not a melanoma, but that would be okay if that was in your differential diagnosis to be confusing this for a melanoma. Nonetheless, a biopsy would be important to rule it out. Next, we have a scar-like papule on the forehead right by the hairline of an elderly person again, and this is a basal cell. Next is a dark, irregular patch, definitely greater than 6 millimeters. This is the elbow of a woman, and this was diagnosed as melanoma. This is a very large nodule on the lower extremity of an old person, and this came back as squamous cell carcinoma. This person actually thought he had a pimple growing near his eyelid, and it is quite a small lesion, but it's not in the best area. Unfortunately, this biopsy came back basal cell, and he would definitely need to have Mohs surgery or referral to an oculoplastics to have this removed. This next elderly gentleman, I think there was a component of dementia in him. He clearly waited a little bit too long to come in, and he definitely has what's known as a rodent ulcer of basal cell carcinoma. This is a younger gentleman with a dark freckle on his nose, and the biopsy on this came back pigmented basal cell. This gentleman, again, waited a little bit too long to come in because not only was his diagnosed as the squamous cell carcinoma, but he also had palpable lymph nodes, which you can sort of see by his ear. There's like a big nodule that's sticking out right in front of his left ear. This is a fairly common presentation of a red nodule that grew pretty quickly in a matter of a few weeks, and this biopsy came back squamous cell carcinoma. This next picture is not something we see commonly. This is a woman who waited a very, very long time to come in, and unfortunately, this was diagnosed as squamous cell carcinoma, and she expired about 2 years after the diagnosis. I want to thank you for your time, and please reach out to me with any questions. Thank you again.